Hi, this is Tom. I just wanted to show you this blog where I talk about the top 10 common mistakes that greenhorn surgeons make. Number 10 is hitting Decimates membrane while entering the paracentesis. And this is really true for me. When I think of beginning eye surgeons, I think of this repeated failed attempts to enter the paracentesis. And the key is to get the cannula just inside the paracentesis and then get the toe down of the instrument by lifting your hand up so that you can slip the instrument under Decimates membrane.
Hi, this is Tom Oetting at the University of Iowa. Here we're going to show you a common problem that residents have as they start surgery, and that is getting into the paracentesis. Dr. Chantry, who's a second-year resident, here shows some trouble he's having getting into the paracentesis in one of his first cases. And the problem is that his approach is such that the toe of the instrument is getting into Decimates membrane so that it can't get into the eye. And the problem is that the approach is too shallow and this toe needs to be more down so that he can get under Decimates. So here I'm demonstrating, I just get into the wound, get the toe of the instrument down so it's under Decimates, and now I'm into the eye. So here I'm showing with my toe up, I can't get in, and as I back out a little bit and put my toe down under Decimates, I can get into this paracentesis.
So number 9 is when residents make the wound too posterior. And this is very common. And the idea is when you start to make the clear corneal wounds, there's a lot of issues, including tilting of the blade, which is very common, in not entering the radial, too long, too short. But when you go too posterior with your start, you can get these conjunctival donuts, which are a big
Hi, this is Tom Oetting, the University of Iowa. I'm going to show you an interesting and common problem called a conjunctival donut. Here you can see that one of our residents is making an incision with a keratome, and it's often the case with a right-handed surgeon. You can see that the right side of the keratome is more posterior. The blade is tilted a little bit, and so the right side of the incision is more posterior than the left. And it's actually into the conjunctiva. And as a result, as the fluid comes out of the eye, it gets underneath the insertion of the conjunctiva and it begins to balloon up. And the way to prevent this is to make your incisions a little bit more anterior. And once it starts, what you want to do is do a very quick peritomy before this donut gets too big. And you can see that if you make that peritomy in time, that you can now have the fluid so that it comes out and goes around the conjunctiva and no longer gets underneath the conjunctiva and creating the donut. Now here you can see this can happen very quickly. We've made our incision, it's a little bit too posterior. We're beginning the phacoemulsification phase, making a groove, and you can see now we began to notice the conjunctiva donut is starting, but look how fast this is progressing. You can see that it's progressing so fast that even though we rush and get the Vanna scissors, that it's already about 1/3 of the way around, and the cat's pretty much out of the bag. And here's another example. Again, it's a right-handed surgeon. You can see that there's a little bit of a tilt so that the right part of the knife is more posterior than the left, and this tilt is very common. Now this is very subtle. There's just a little bit of tilt, and it's just a little bit too posterior on the right. The insertion of the conjunctiva is anterior to our wound, and as a result of that, the conjunctival ballooning has begun. It's almost 270 degrees around by this point. You can see that the fluid is building up such that it's sort of caught like in a volcano where the fluid is trapped right over the cornea. This creates a meniscus lens, a negative meniscus lens, which causes a lot of distortion and glare, minimizes the view, and can make things quite tricky. You can use gauze and Weck cells to try to deal with it. But the key to this is really to try to prevent it and early detection in that peritomy. This is Tom Oetting at the University of Iowa. Thank you very much.
Number 8 of the greenhorn mistakes is not using enough fluid during hydrodissection. Hydrodissection is a fairly forceful event during surgery, and one of the mistakes that often is made is just dribbling the fluid in. What you want to do is get the capsule, get just under the capsule with a cannula, and then you squirt fairly forcefully. You push down a little bit on the lens, squirt again, push down the lens, and really it takes a fair amount of fluid to do it. You should go quickly through the 5 cc syringe if you're at the proper rate. Number 7 on the list of greenhorn mistakes is lifting up too much on the wound when using the phaco handpiece. When I was first getting started, I used to think that it wasn't fair that Dr. Johnson, who is one of our great surgeons here at the University of Iowa, had an eye which was always so stable, and that when I was operating with him, the eyes were moving all over the place. And it always struck me as odd. And then until I finally realized that the reason the eyes were moving is because I was moving them, because I wasn't keeping that wound stable. And so you have to keep the wound stable. If you lift up, the eye will move over. If you push down, the eye will move towards you. And the wound itself has to stay in the same place, the same position at all times during the surgery. Number 6 of the greenhorn mistakes is that you make a long wound and you hydrate the wound with a phaco tip. You hang out with the phaco needle in the wound, and you end up having a long edema section of the cornea, edematous section of the cornea. Here you can see the keratome starting a little bit anterior, and the tunnel is going to be really long in this case. You can see the tunnel's going, it's still going, it's still going. And really it's almost, to the midway point of the cornea. Now as the case proceeds, because you can see there's a lot of irrigation that's going into the cornea, with time, this section of the cornea becomes increasingly edematous, which is not a surprise. And as a result, it becomes increasingly difficult to see the subincisional area, which will make removal of the subincisional cortical material quite difficult. You can see now by this point in the surgery when we're doing IA, we can barely see in the subincisional area. In addition, the long tunnel makes distortion a difficult issue as well. So one trick you can do in this situation is you can come out and you can get that material through a paracentesis. You can also place the lens and then take it out, which might be easier. But you can just gives you an idea with how difficult it can be when you have a long anterior wound and you hydrate in that wound and you get a lot of edema. Spinning the lens is number 5 in greenhorn mistakes. Stressing the zonules during spinning the lens is really a tricky thing to watch if you're the attending surgeon. Spinning the lens is a very difficult step for most people to learn. What you're doing is you're converting linear motion with the second instrument into rotary motion of the lens. And so you have to think like you're a little steam engine, and you're rotating that wheel just like the steam engine moves the drivetrain on the engine. And so you have a single point of contact. So your Drysdale, whatever instrument, attaches to the lens in one place, and then you have to maintain the same diameter as you go around. I think it's very important to sort of try to visualize that as you're doing it. I think a Drysdale is a good instrument, or a horizontal chopper, to allow a single point of contact. When you reach across the lens, sometimes you'll scrub on areas of the lens that aren't the single points of contact and can make it trickier. But working on spinning without stressing the zonules is very important. Number 4 greenhorn mistakes is not making the groove deep enough. You want to visualize a perfect groove. What is a perfect groove? Well, a perfect groove is about 1 1/4 or so widths of the 1 millimeter phaco tip. You go wider if the lens is harder. You go more narrow if the lens is soft. You want to have the central aspect of the groove deeper than the peripheral. You want to have very straight walls, and you want to have no speed bump in the center. And if you, at your leisure, if you look at this video, we outline how to make a nice groove. When residents are learning how to chop, the most common issue is not being able to hold on with the phaco needle. And this is usually not a vacuum problem or a setting problem or something wrong with the needle. The most common error is that when people reach out with the chopper, they pull back on the phaco needle. So after initially getting a bore into the nucleus and you have a decent hold, what happens is when you go out with the chopper, a lot of people will pull back with the phaco needle because you're trying to pull the lens away from the capsule, which you can't do because you can't move the lens inside the capsular bag that much. So what you have to do really is sort of tell yourself to push forward a little bit with the phaco needle, sort of push the nucleus down a little bit as you go out with the chopper. But don't pull back, because if you pull back, you'll lose your grip every single time. Number 2, phaco greenhorn mistake is problems using the second instrument. It takes a while to learn how to use the second instrument. And funny things often happen when you first introduce the second instrument. You lose track of your first instrument. You push the two instruments together so you get funny distortions. You have AP issues where one instrument is higher than the other. Fluid starts pouring out of the second instrument. So all this stuff happens when you introduce the second instrument. Similarly, you sometimes have trouble keeping the eye stable because not only do you have one wound to keep track of, now you have 2 wounds to keep track of. And that can make centration of the eye very difficult. Here's an interesting video. You can see that we're making our wound, but look how close our wound is to the paracentesis, which was made first. So one thing to remember is always think about where the wound's going to be and then make the paracentesis. But because the paracentesis is way too close to the wound, you can see several things are happening. One is the eye's moving way over towards the nose because of the vector forces of those 2 wounds so close to each other. The other is there's a lot of fluid pouring out of that paracentesis. And the instruments are just bumping all over each other and getting in the way. So all you should do at this point is just make yourself another paracentesis. You can have a lot of paracentesis in the eye and not have trouble. So just make another one that's another 30 or 20 degrees away from the first one, and you'll find that the case will go much, much better. Just because you have a paracentesis in a bad spot doesn't mean you have to stick with it the rest of the case. Don't hesitate to make another paracentesis. You can see we're having a lot of trouble rotating the lens, and it's just really difficult. It's way over towards the nose right now. It's just really, really not going so great. And a lot of this just simply has to do with the poor placement of the wound relative to the paracentesis. And the number 1 greenhorn mistake is not knowing important details about the patient's ocular medical history. This is the one thing that bugs me when I'm with young surgeons, because when you think about learning cataract surgery, you realize that you're adding risk to that patient because you're just getting started. And so the one thing you can do, because you're close to your internship, you're close to medical school, the one thing that you can do is know really well the patient's history, the patient's medical history, the patient's ocular history, all the details, because that's where you can really add value. You need to know what medicines they were on, especially Flomax. You need to know if they have diabetes. You know if they've had past refractive surgery, if they've had past vitrectomy. You've got to add some value to the patient. You've got to take real care at knowing about this. Have a checklist, have a sheet that spells it all out so you really have a good sense for what's going on. Because when the going gets tough, and we need to know, did the patient have a vitrectomy in the past? Did the patient have diabetes? Does the patient have Flomax? You need to be able to say yes, no, yes. You need to know for sure, because that's one of the most critical jobs you have when you're learning as a young resident. Well, this is Tom Oetting at the University of Iowa. I just wanted to go over, in my opinion, the top 10 common mistakes that greenhorn surgeons make from this blog that we have called Cataract Surgery for Greenhorns. Thank you very much.